Hello, my name is Joe Furman, and I'm a neurologist, and I work in the departments of otolaryngology and neurology at the University of Pittsburgh School of Medicine. I'm going to be speaking to you about the topic of dizziness and disequilibrium. I'd like to get started by posing three key questions that you should be asking yourself when you see a patient with dizziness and disequilibrium. First, how do you determine whether a patient has a benign cause of dizziness and disequilibrium? Second, how does the physical examination confirm your suspicion of a benign cause of dizziness? And third, how do you treat patients with dizziness and disequilibrium? Dizziness and disequilibrium can come in several forms, one of which is lightheadedness or faintness. This is a nonspecific complaint that can be a result of a disorder of many different organ systems other than the brain or inner ear. In particular, abnormalities of the cardiovascular system, such as orthostatic hypotension, can present with lightheadedness or faintness and be called dizziness by the patient. So it's important to check orthostatic pressures. Some patients with abnormal ambulation, disequilibrium of gait, particularly benign disequilibrium of aging, can actually complain of dizziness even though they're actually off balance. Multiple sensory deficits can occur, particularly in diabetes, when there is an association between peripheral neuropathy, vestibular problems, and diabetic retinopathy. These patients can have multiple sensory defect dizziness. And some patients with anxiety may present with lightheadedness because of hyperventilation or actual panic attacks. Some patients with dizziness actually have vertigo. Vertigo is appropriately used to describe an illusory sensation of motion of self or surround. It doesn't really matter whether the patient feels as if they are moving or the world around them is moving. These are equally classifiable as vertigo. Vertigo can be physiologic or pathologic. Physiologic vertigo can occur during balance testing, such as caloric testing, and can also occur when turning in circles and then stopping abruptly. Pathologic vertigo, that is vertigo that should not occur, can be of a peripheral vestibular origin or a central vestibular origin. Briefly, anatomy and physiology of the vestibular system. The peripheral vestibular system is comprised by the inner ear structures themselves, the eighth cranial nerve, and some people will even include the root entry zone where the nerve enters the brain. The central vestibular system is comprised by all of the structures that are important for conveying inner ear vestibular information to various locations, such as to the eye movement centers, the postural control centers, the cognitive centers important for disequilibrium, and the autonomic nervous system. Briefly, the physiology of the vestibular system is best characterized by considering the vestibulo-ocular reflex, often called the VOR. This is a diagram of the peripheral vestibular system. And what you'll note is that there are 3 loops called the semicircular canals that sense rotation about all axes in space. Also, you will note the presence of the utricle and saccule. These organs sense which way is up. That is, they are gravity sensors. They also sense linear motion. A problem with any one of these 5 suborgans can lead to dizziness or disequilibrium. You may also note that there are 2 branches of the vestibular nerve, one of which receives input from 2 of the semicircular canals in the utricle, and the inferior vestibular nerve that receives input from the saccule and the posterior semicircular canal. Here is a diagram of the vestibulo-ocular reflex. The vestibulo-ocular reflex is important for maintaining the eyes on target. If, for example, the head is rotated toward the left, there would be an excitation of the left peripheral vestibular system and a decrease in activity on the right. This difference in activity, left and right, will lead to an eye movement to the right, head movement to the left, eye movement to the right. There are several different structures in the brainstem that are important for mediating the vestibulo-ocular reflex, as shown on this diagram. There are numerous causes of vertigo. Here is a list in alphabetical order of the peripheral, that is, inner ear causes of vertigo. And many of these disorders will be discussed, though some only briefly. The 3 disorders that are in red will be discussed more thoroughly because they're so common and likely to be encountered. These include benign paroxysmal positional vertigo, Meniere's disease, and vestibular neuronitis, often called vestibular neuritis or even labyrinthitis. Central causes of vertigo, that is, causes of vertigo based upon brain abnormalities, are several, and I have highlighted in red migraine-related dizziness, currently known as vestibular migraine, because it is the most common central cause of vertigo. Let's talk about the symptom patterns of vertigo. First, benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo is often called simply benign positional vertigo. It's easier to say. Some patients will also call this condition vertigo. So if your patient says, "Doctor, do I have vertigo?" usually what they mean is, do I have benign paroxysmal positional vertigo? The pathophysiology of this condition is cupulolithiasis, which we will talk about more later. These patients typically have normal hearing and intermittent episodes of vertigo, particularly when turning in bed, and it is the most common cause of vertigo. Vestibular neuronitis, also known as vestibular neuritis or labyrinthitis, is typically characterized by normal hearing and the sudden onset of severe, constant vertigo made worse by head movement. This condition generally resolves over days to weeks, rather than benign positional vertigo, which lasts only seconds. Meniere's disease is a condition categorized by intermittent episodes of vertigo lasting for minutes or hours, typically accompanied by unilateral hearing loss, unilateral tinnitus, that is ringing in the ears, and lateralized earfulness, typically on the same side. Migraine-related dizziness, now known as vestibular migraine, is another episodic vertigo condition often seen in combination with migrainous-type symptoms, particularly headache, but can be seen with other non-headache migrainous symptoms, such as phonophobia and photophobia. Usually there are no otologic symptoms with vestibular migraine. Now let's talk about the clinical history and physical examination that can be performed to determine why your patient has dizziness and disequilibrium. First, does your dizzy patient have vertigo? We noted that vertigo is an illusory sensation of motion or surround, sometimes called true vertigo, and this accounts for roughly half of the causes of dizziness. Many patients with dizziness actually do not have vertigo. Ask about specific circumstances when the vertigo occurs. Ask about the presence of other neurologic or otologic symptoms and whether or not the dizziness is recurrent. These characteristics are often more important than the specifics of the type of dizziness. Patients often wish to describe their dizziness, but these other factors are more important. Also ask the following questions. Are the symptoms characterized by a sense of motion, such as spinning or rocking or tilting? Vertigo does not necessarily mean that the patient feels as if they or the world is spinning. There may be a rocking or a tilting sensation caused by abnormalities of the gravity sensors of the inner ear. Is there a sense of imbalance when walking, such as veering to the right or left, or concern about falling? Although disequilibrium only accounts for a few percent of dizziness, it is extremely important to ask about disequilibrium because of the risk of falls. Does your patient have a benign cause of vertigo? 40% of dizzy patients will have a peripheral vestibular disorder affecting the inner ear or the eighth cranial nerve. Benign positional vertigo, vestibular migraine, Meniere's disease, and vestibular neuronitis are the most frequent diagnoses. It is important to inquire about associated hearing loss. For patients without associated hearing loss, the likelihood of a cerebellopontine mass, such as an acoustic neuroma, is very low. You should inquire whether your patient's vertigo is episodic or persistent. With no hearing loss and episodic, brief, intense vertigo, your patient is likely to be experiencing benign positional vertigo. With no hearing loss and the acute onset of persistent, particularly severe vertigo lasting for hours to days, with nausea, is most likely vestibular neuronitis. You should inquire about associated otologic complaints. Peripheral vestibular disorders are often associated with otologic complaints, such as hearing loss, tinnitus, or earfulness. Hearing loss and episodic vertigo lasting for hours with tinnitus and a sensation of earfulness is most consistent with Meniere's disease. Hearing loss and severe persistent vertigo lasting for hours to days with nausea is most consistent with labyrinthitis. Labyrinthitis is often used synonymously with vestibular neuritis, but appropriately, labyrinthitis should be reserved for patients who have both balance involvement and hearing involvement of the inner ear, that is, a problem with both the vestibular labyrinth and the cochlea. Does your patient have a central cause of vertigo? Roughly 10% of all dizziness may be central in origin. It is essential that you inquire about associated neurologic complaints. Central vestibular disorders are more likely to be associated with numbness, weakness, and incoordination. These are clearly of neurologic origin. Further, you should inquire about antecedent trauma and a history of migraine, as these can be important for diagnosing a central cause of vertigo. It is important for you to review the medication list for all of your patients who present with dizziness, as many medications have dizziness as a side effect. As mentioned previously, is your patient orthostatic? Also, does your patient have an abnormal neurologic examination that can hint at a central abnormality? And assessment of gait is absolutely essential. Does your patient have an abnormal ear examination? Ear drainage is seen as a complication of chronic otitis media, along with hearing loss and vertigo. Ramsay-Hunt syndrome may be identified by the presence of vesicles in the outer ear, hearing loss, and facial palsy as a result of a herpes zoster infection. The association of abnormal neurologic signs and symptoms with dizziness suggests a central problem. The association of abnormal ear signs or symptoms suggests an otologic, that is, peripheral cause of dizziness or disequilibrium. I want to mention a few special examination tools that can be helpful in evaluating the dizzy patient. These examination methods are not part of the typical neurologic or otologic evaluation, but can be very helpful. They include the Dix-Hallpike test to specifically evaluate patients for benign positional vertigo. I will show you a picture of that. It can also be helpful to assess your patient's stability when standing on a foam pad, because this increases the challenge of maintaining balance and removes somatosensation. The stepping test, that is, having your patient march in place with their eyes closed, can be helpful in some cases, looking to see if the patient turns in a circle. And lastly, the head thrust test is a new method that is becoming popular to assess peripheral, that is, inner ear function, by rapidly moving the patient's head to the right or left, looking for abnormal eye movements. In some selected patients, laboratory testing may be indicated. This is often so for those patients who are not diagnosed by your history or physical examination. Selected blood tests may be helpful. Vestibular laboratory testing may be helpful. Audiometric testing may be helpful. And in some patients, brain imaging is appropriate, including computed tomography, CT, and magnetic resonance imaging, MRI. And these images can be specifically targeted to the inner ear structures or the posterior fossa of the brain, which is the area most important for balance. I'd like to now go on and talk about benign paroxysmal positional vertigo in particular. This is often labeled BPPV or simply BPV. The pathophysiology is canal lithiasis, and I'll show you more about that. The diagnostic procedure is the Dix-Hallpike maneuver, and the treatment is particle repositioning. Here is a diagram of the Dix-Hallpike maneuver for the right ear. You will note that the patient's head is turned approximately 45 degrees toward the right, and then the patient's head is brought rapidly into the head hanging position while maintaining the head turn toward the right. The eyes are observed looking for a characteristic upbeating torsional nystagmus, with the upper poles of the eye beating toward the down ear, in this case the right ear. Also shown on the diagram is an artist's drawing of the particles that are moving inside the inner ear that cause the benign positional vertigo. Shown on this slide are the crystals, the otoconal debris that actually moves inside the inner ear in a patient with benign positional vertigo. Here is shown the treatment maneuver for a patient with right-sided benign positional vertigo. After the patient has reached the head-hanging position, their head is then rotated toward the opposite ear, that is the left ear, and then the patient is rotated further such that their nose is facing the floor. During this maneuver, many patients experience some dizziness. After the patient's dizziness ceases, they are returned quickly to the seated position. This accomplishes a particle repositioning, that is, the otoconal debris, the canal lithiasis, is moved from the posterior semicircular canal to the vestibule. This treatment maneuver is extraordinarily successful in a very high percentage of patients. In those patients who do not respond to the particle repositioning maneuver or who cannot undergo the maneuver for one reason or another, there is an alternate treatment called Brandt-Daroff exercises, and they are shown in this diagram. Now let's talk about Meniere's disease. Meniere's disease is characterized by vertigo, unilateral hearing loss, tinnitus, and ear fullness. The tinnitus and ear fullness are usually on the same side as the hearing loss. The pathophysiology of Meniere's disease is endolymphatic hydrops, that is, swelling and increased pressure in the inner ear endolymphatic channels. The diagnosis is often made by finding a low-frequency sensorineural hearing loss on audiometric assessment. The treatment for Meniere's disease consists of decreasing sodium intake. Dietary sodium intake should be reduced to 2,000 milligrams per day or less, and also diuretic therapy, typically with a combination of hydrochlorothiazide and triamterene. This is an artist's drawing of endolymphatic hydrops showing ballooning of the utricle and saccule of the inner ear. Now let's talk about vestibular neuritis, vestibular neuritis, also sometimes incorrectly called labyrinthitis. These patients have an acute vestibular syndrome. The pathophysiology of this condition is inflammation of the eighth cranial nerve, presumably based on a virus. The diagnosis is typically made by finding a unilateral caloric reduction. Oftentimes, this diagnosis can be made without laboratory testing based on the patient's presentation. The treatment for vestibular neuritis includes steroids. Antiviral agents have not been found to be helpful, either alone or in combination with steroid treatment. Vestibular suppressants, particularly in the early stages of vestibular neuritis, is appropriate so that your patients are more comfortable, and in particular if they have nausea and vomiting. Damage to a single labyrinth, such as occurs with vestibular neuritis, can lead to numerous signs and symptoms, including vestibular nystagmus, gait instability, spatial disorientation, autonomic symptoms, including nausea and vomiting, changes in heart rate, and changes in blood pressure, including by both hypotension and hypertension. Now let's talk about vestibular migraine. Vestibular migraine, previously called migraine-related dizziness, is a condition that is quite common, and the diagnosis is based upon clinical criteria that we will review. The pathophysiology is uncertain. The treatment for vestibular migraine is similar to that for other migrainous disorders such as migraine headache. Recently, the International Headache Society and the Baronnet Society have agreed upon diagnostic criteria for vestibular migraine. These diagnostic criteria include a current or previous history of migraine based upon International Headache Society criteria. Also, patients should have episodes characterized by vestibular symptoms that are of moderate or severe intensity. And importantly, in association with the vertigo, there should be migraine features such as headache, photophobia, phonophobia, or visual aura. And lastly, the patient's symptoms should not be better accounted for by another vestibular diagnosis or another headache diagnosis. There are numerous treatment options for patients with vestibular migraine. These include avoiding dietary and other migraine triggers. Also, pharmacotherapy can be beneficial and can include medications from 5 different families of medications known to be helpful for some patients with migraine headache. These include antidepressants, beta blockers, calcium channel blockers, triptans, and anticonvulsants. Also, patients with vestibular migraine should be considered for vestibular rehabilitation therapy, particularly if they have movement-associated disequilibrium. Some patients with vestibular migraine are particularly sensitive in certain environments, such as grocery stores and shopping malls. These patients may benefit from treatment with low-dose clonazepam. Some patients with vestibular migraine have an associated anxiety disorder or panic disorder. These patients may benefit from behavioral therapy and also from pharmacotherapy, particularly antidepressants and anxiolytics such as benzodiazepines. Now that we have talked about most of the frequent causes of dizziness and disequilibrium, we can talk about some conditions that are not quite as common. Disequilibrium of aging is seen in individuals who have deep white matter disease on their magnetic resonance imaging scan and are of advanced age. These patients thus have age-related disequilibrium and should be treated with physical therapy. It is important to avoid sedating pharmacotherapy in these patients, and also these patients do not benefit from vestibular suppressants. Labyrinthine concussion is seen in individuals who have had head trauma. And although the pathophysiology of the condition is unknown, these patients often will have a reduction in inner ear balance function and have variable signs and symptoms in addition to their brain concussion symptoms. The treatment for this condition, that is labyrinthine concussion, consists of physical therapy. Vertebrobasilar insufficiency is a condition that we now know is unusual. The reason that we know it is unusual is the availability of non-invasive imaging. However, some patients do in fact have vertebrobasilar insufficiency on the basis of inadequate blood supply to the vestibular labyrinth or the brain structures important for balance. The diagnosis of vertebrobasilar insufficiency can be aided by angiography. The treatment includes antiplatelet therapy and, in rare cases, interventional radiology. Here is a diagram of the blood supply of the central vestibular structures, including the brainstem and cerebellum. And you will note that the vertebral artery and its various branches are essential for providing blood supply to the central structures, important for dizziness and disequilibrium. The vestibular labyrinth also has a blood supply. As you can see in this diagram, the blood supply to the vestibular labyrinth is supplied by a branch, that is the anterior vestibular artery, and another branch, the posterior vestibular artery, that arise ultimately from the anterior inferior cerebellar artery and the basilar artery. This slide should remind us that patients who have dizziness and disequilibrium that we believe is on a peripheral basis may in fact have a vascular rather than viral etiology for their abnormality. Panic attacks. Patients with anxiety who manifest panic attacks can often experience dizziness, vertigo, and uneasy feelings such as disequilibrium, in addition to having a sense of apprehension and fear, trouble breathing, palpitations, chest discomfort, and other complaints such as sweating, faintness, and trembling. It is inappropriate to attribute all patients' dizziness to anxiety, even when the patient is anxious because of their dizziness. But it is important to remember that some patients have dizziness on the basis of their anxiety. A disorder that is not frequently seen but must be kept in mind is that of ototoxicity. Ototoxicity is typically caused by inner ear hair cell loss because of aminoglycoside antibiotics or cisplatin. Those are the most common causes of ototoxicity. These patients often present only after they have had so much vestibular loss that they have oscillopsia, that is a jumbling of the visual surround with head movement, and ataxia, that is unsteady gait. The diagnosis is confirmed by a reduction of balance activity in the laboratory. Treatment for these patients is challenging. Physical therapy can be helpful, as can other sensory aids. Lastly, I want to talk about nonspecific vestibulopathy. That is, patients in whom we think there is a vestibular abnormality, probably peripheral, possibly central, but of unknown origin, despite our best efforts to establish a diagnosis. These patient signs and symptoms may be variable, and the patient should be treated symptomatically once we have ruled out worrisome causes of dizziness and disequilibrium. The categories for treating nonspecific vestibulopathy include anti-nausea agents, vestibular suppressants, anti-anxiety agents, antidepressants, and vestibular rehabilitation therapy. Let's examine a few of the medications commonly used to reduce dizziness, vertigo, and associated nausea, regardless of etiology. The most common is meclizine. Meclizine can be helpful for your patients with dizziness, but does have a side effect of drowsiness. Also, meclizine, by reducing vestibular function, is inappropriate for long-term use. Other medications in this category include dimenhydrinate and cyclizine. Benzodiazepines, such as diazepam, can also be helpful for reducing your patient's symptoms, but should not be used long-term. In the benzodiazepine category, clonazepam can also be a therapeutic choice in addition to diazepam. Prochlorperazine and promethazine can be used for your patients with nausea. Also, your patients may benefit from trimethylbenzamine, diphenhydramine, and hydroxyzine. These medications are often reserved for patients who have severe nausea and sometimes vomiting in association with vestibular neuritis. Let's review treatment principles, particularly for patients with nonspecific vestibulopathy, but also treatment principles that can be helpful for your patients with other diagnoses. If you can establish the diagnosis of a specific disorder, that disorder should be treated specifically. A short course of vestibular suppressants is often helpful, particularly for your patients who have nausea and possibly vomiting in association with their dizziness. Treat nausea, treat anxiety, particularly if it's in association with dizziness, and treat your patient's imbalance with physical therapy. So in conclusion, regarding dizziness and disequilibrium, try to determine whether or not your patient has a benign cause of dizziness and disequilibrium. Secondly, use the physical examination to help confirm your suspicion of a benign cause of dizziness. And third, treat your patients who have dizziness and disequilibrium for specific etiologies if possible.